whilst you're getting your questions ready on Slido, and particularly those of you online, if you'd like to post your questions, does anyone have any questions in the room? If so, please put your hand up. We have the throwing microphone. We didn't get to use this yesterday because nobody be brave enough to put their hand up in the audience. But is anyone brave enough today to have this thrown at them? Yes. Right, who's that? Oh. Are you ready? I'll try. Woo! I tried my best. Somebody throw it on to Robert. Right. I don't know if is it working, guys? Oh no, after all that. Can we get a roving mic then to Robert? I'm sorry, Robert, that really spoilt the game.
It was good fun, though.
It was good fun.
This is a message, a question for James.
James.
How similar do you think PCD is to CF, to non-CF bronchiectasis? Does that make sense, the question?
Yeah, completely. I think they are all different, but they have similarities. So I think that the similarities with PCD and CF are primary mucociliary clearance defect, people who develop, in most cases, bronchiectasis in childhood, have symptoms earlier than most of our idiopathic bronchiectasis patients who develop symptoms in adulthood. As you see from Marcus's work, you see similarities in terms of inflammation pattern and mucus rheology properties, etc. So the treatable traits are quite similar. But I think there are also enormous differences between all of them. But that's the challenge that we're looking into here, because NTM patients are different from idiopathic bronchiectasis patients, are different from connective tissue bronchiectasis patients. So you have an umbrella diagnosis, which is bronchiectasis, and then you have all of these different biologies that we're trying to target. So the question is, do we do trials in very pure populations, which may not be feasible for some of those populations, or do we do, where the treatable traits are common across all of them, some of these basket-type trials? I think, to come back to PCD, the trial I did, which is Aspen's, the largest PCD trial ever conducted. It's very unlikely somebody would have done a direct anti-inflammatory trial in PCD, but they'll be included now in the regulatory approval because they were in the basket. And maybe that's something to think about in the future. If people are not going to take some of these treatments into modulated CF patients, you may still be able to get drugs to patients by, where it's appropriate and where the biology makes sense, putting people into the basket.
Now, I gather this is working now. Thank you, James. We maybe try that again in a minute. Thank you. A question for CF Start, Alan. What is your impression on why recruitment was slower than anticipated?
That's a really good question and quite a difficult one. So first of all, recruitment is always slower than anticipated because investigators put ambitious targets on recruitment, otherwise they wouldn't be funded. And that's the truth. And honestly, no-cost extensions are common because we often underestimate how long it's going to take us. I think it's fair to say that once recruitment got going, it was very steady and became embedded in clinical practice, which I think is really important. And I think one of the arguments, one of the real advances that has come from CF Start is that research became, first of all, it gave hope to families with a new diagnosis way before modulators were widely available. So we could temper the bad news of the diagnosis with the good news of clinical trial participation, and also it helped embed research into clinical practice and make it as seamless as possible.
Thank you. I have a question for Jo. Can you hear okay, Jo? Yes. How would a person with CF go about accessing phage or finding out how it might work for them if there are few antibiotics left that work? So
I think the advice would be to talk to their clinician first, but there is now the central contact at UKCFC. So there is Josh Jones, who is, or Mark Sutton, who are leading that service now. But really, it's a conversation with your clinical team at the first point.
Thank you, Jo. Question for Jane and Alex. Pulse and precision. Was info from use of radiology diagnostics considered to predict which microbe is likely to be causing infection? We use radiology regularly as AR, and clinical use of HRCT has become more liberal. Can you answer that question?
We didn't put CT in, and the problem is you can't do absolutely everything. There is a limited envelope, there is a limited delivery team as well, so delivering radiology at scale is expensive and takes a lot of time to get things set up. So we have to take a sort of pragmatic approach, and indeed, you know, the CF tracker study has a very pragmatic design as well. It's designed to be deliverable in units and tolerable to patients. So CT, you know, it does put some patients off. It is hard to deliver. We have to sort of balance the information content from that. I know that with the one bronchiectasis approach, the intent is to include CT, but that's a different set of questions being asked.
Mm-hmm. Do you have anything to add to that, Jane?
I think it's an interesting question, actually, but my quite strong impression is there is a couple of organisms that look quite characteristic on imaging. Atypical mycobacteria, for example, or fungus. But when we come down to all of the other range, particularly of the bacteria that cause, I've never read any evidence or sort of had any inkling that even the best radiologist can look at a scan and go, well, that's definitely staph. And so, to be honest, it never really came into my mind as something that we could do. I think we are starting to think about CT, and certainly we're doing a lot more MRI as part of a research study, and it could possibly be something that we could apply retrospectively, that we could go back and have a look at people's imaging and see if we get any mapping onto that, and perhaps that's something that would lend itself to a much bigger group doing that. But I would be quite surprised if it tells us anything very specific about infection as opposed to the stage of progression of lung damage.
Okay, thank you. Back to James. Is there scope for organisations across bronchiectasis and CF and other respiratory diseases conditions, for example PCD, to work together to further research and trials? Charities working in each area, for example, perhaps a combined CF bronchiectasis and PCD CTAP?
I think the answer to that is yes. It makes complete sense that if a large proportion of trials, and we don't know yet whether it will, how large the sort of basket trial field will be, but if there's going to be a large number of trials that do this, that our structures evolve to accommodate that, there's no question there will continue to be single CF trials because gene therapy, for example, doesn't make sense in non-CF. Likewise, in PCD, there are attempts to do gene correction for PCD. There is going to need to be trials that are exclusive to PCD. And there will be many sponsors, and we got this feedback at the ERS, who don't see CF as part of their development programs for various reasons because they think their biology is better mapped to other causes. And so we will need to have an ecosystem that evolves to both support joint trials and an ecosystem that allows individual diseases to do clinical development individually where that's appropriate. So that means working together, communicating, and constantly evolving how we do delivery.
Thank you. Staying with you for a little bit, James, but also to include the other people on the panel as well. Some of our patients don't know that they have bronchiectasis. Can you give us tips on how to explain that it's a part of CF, not another complication comorbidity, e.g. when introducing the airtivity trial?
Yeah, that's a really good point. Before I do that, I'll do the other side, which is we constantly think about CF and bronchiectasis as separate, but many of our bronchiectasis patients don't realize that they have CF. We've done a recent study where 6 patients enrolled in a non-CF bronchiectasis study were tested and had cystic fibrosis. So it works the other way around as well, and we need to also keep that in mind from a commonality point of view. So in terms of explaining to people about bronchiectasis, that's obviously our business all the time. is explaining that this is a cause of lung damage. I assume patients with CF are told from a very early age what the biology of this is in terms of thick mucus. When airways are obstructed with mucus, you get damage to the airways. They widen, and that becomes permanent over time, and that permanent lung damage is called bronchiectasis. And so that, I think, is the way I would explain it to people in terms of the biology of the disease. And so the treatment that you would get in Airtivity or any of these other trials is attempting to treat a complication or a consequence of the cystic fibrosis, which is very common. Likewise, I'm sure people with CF understand that they may have diabetes as a result of their CF. Diabetes is another consequence. It is a disease, but it is also a consequence of their underlying condition.
Anybody else got anything to add to that? No? Okay. So a further question for Jane and Alex. It feels as though there's quite a lot of overlap between hubs. How can this be managed to minimise waste and make best use of CF Trust funds?
I think that's a really good point, and it is something that we've been sort of requested to focus on, and I think are also focusing on. So the best example probably is Alex and Liverpool getting together to unify their study, which actually is, it takes a bit of something for a PI to say, okay, I'm going to just like share this. This is my baby, but let's do it together. So I think it's a really great example that it can be done, and it makes total sense. I think that what we would like to benefit from the expertise of other hubs. So Jo and I have had a lot of conversations in the lead up really to the applications going in about how we can balance each other's areas of expertise. And I think that that will definitely be something that will be really, really useful in the fullness of time. We've signed up at Brompton to be one of the sites recruiting to Alex and the Liverpool study. So, you know, as much as possible, this is happening. And I think all of us are open to other suggestions for how it could happen better. There is somewhat a sense that we need to be walking before we can run, I think, on this. And all of us are really, really busy trying to tool up. So trying to sort of do everything at once is a little bit challenging. But in the fullness of time, I think it's something that will definitely, all of us are very, very positively disposed towards it.
Yeah, and I think, you know, full credit here to CF Trust and LifeArc. The ethos of this call right from the outset was that this was a collaborative hub network, and there are a number of activities that happen on top of the sort of direct research to bring us together. So it was very much sold as a collaborative network. It's been lovely working with Jo and Freddie. They've been very, very open and straightforward to work with. We're obviously physically quite close together. We have very similar ambitions for the study, and it's allowed us to create a study that's bigger and better than each of us had originally envisaged. In terms of working with the Brompton, obviously, Jane and I have known each other for a long time, and we are collaborating and looking at how we can do that. And we've provided our data dictionary to ensure that the data fields being collected are comparable. And I think, you know, down the line we will try and ensure that all the sort of appropriate overlaps are optimized and the synergies are optimized as best we can. There are different objectives as well. So it's, you know, we're not trying to do the same thing, obviously.
So we're eating enough to our lunchtime a little bit now, so I have two last questions. There's lots more, but for those who've asked questions, we'll try and see if we can get them emailed to the relevant person. Will future Gremubumab trials, have I just said that right? That's quite a mouthful, isn't it? Trials be extended to people with CF. Quick answer, please.
Quick answer, I hope so, is the answer. That presentation I just gave was a pitch to try and persuade people to do so, because I think it makes a lot of sense.
And there is another question here, Jane, but it's tell us about the sniffer dogs. Now, I suspect this might be quite a long answer. They're lovely, soft, warm and cuddly, and they do a good...
See you at lunch, whoever that is.
I think we need a one
about them for
bronchiectasis
hours.
sniffer dog study, because I want some dogs in my...
Bring a video next time, yeah.
Okay, so I just think to thank you all for your presentations today, especially you, Jo, for joining us online. It's been a fantastic morning, and I think you've really shown what we're doing to push forward how we diagnose and treat infections in the CF lung. So thank you to all of our speakers.